Good morning everyone. This is Dr. Vidya Selvam, Associate Professor in Department of Obstetrics and Gynecology in Sree Balaji Medical College and Hospital. Today we are going to discuss about an important topic, postpartum hemorrhage. Postpartum hemorrhage is the leading cause of maternal mortality around the world. It is a nightmare for all the treating obstetricians, the mother, her family and everyone involved in the maternal care. At the end of today's session, a student will be able to understand definition and types of postpartum hemorrhage, causes of postpartum hemorrhage, identification of postpartum hemorrhage and resuscitation in a woman with postpartum hemorrhage, medical management of PPH and surgical management of PPH. What is postpartum hemorrhage? Postpartum hemorrhage is excessive bleeding from genital tract after delivery. What is excessive bleeding? It is more than 500 ml after vaginal delivery, more than 1000 ml after cesarean section, or any amount of blood loss that results in hemodynamic instability. Depending upon the severity, it is classified as minor PPH and major PPH. Minor PPH is blood loss of 500 to 1000 ml and major PPH is blood loss of more than 1000 ml. Depending upon the time of onset of PPH, it is classified as primary PPH and secondary PPH. Primary PPH is onset within 24 hours after delivery and secondary PPH is onset from 24 hours after delivery to 12 weeks postpartum. Cause of postpartum hemorrhage. Primary PPH. There is a mnemonic T, 4 T's. So T, tone, trauma, tissue and thrombin. Tone is atonicity, that is uterus fails to contract after expelling the placenta. Trauma to the genital tract. Tissue is the placenta, it is retained placenta. Thrombin, it is a coagulation abnormality. Secondary PPH causes could be due to infection, placenta, arteriovenous malformations and gestational trophoblastic neoplasia. Management of PPH starts from anticipating risk factors, reducing the risk factors, precautions when risk factors are present, diagnosing PPH earlier and initiating the treatment. So to whom PPH should be anticipated? Every woman in delivery is at risk of PPH. There are some risk factors that make her more prone to develop PPH. They are either antepartum risk factors or intrapartum risk factors. Antepartum risk factors are abnormal placental implantation, that is placenta accreta, increta and pecreta, placenta previa which increases the risk by 12 times, preeclampsia 5 times, multiple pregnancy 4 times risk, polyhydramnias, macrosomia, grand multiparity, maternal anemia which is a major risk factor for PPH, maternal obesity and maternal age. A maternal age is in the either scenarios, both teenage pregnancy and elderly gravida are prone to develop PPH. The intrapartum risk factors are any operative delivery. It could be emergency cesarean section, elective cesarean section or instrumental deliveries. Induced labor, prolonged active labor more than 12 hours, episiotomy which is not given at the right time and maternal pyrexia in labor. What is the right time to give an episiotomy? It is crowning. That is the presenting part. The fetal head is visible between the labia without separating and it doesn't recede back in between contractions. Episiotomy should be given at that time. If it is given earlier, there will be increased blood loss. One of the correctable risk factor for PPH is anemia. So how to reduce the incidence or prevalence of anemia? First is to prevent maternal anemia. That is to provide adequate blood store in the woman's body itself. Our government has suggested all women in pregnancy should take at least 100 tablets of iron and folic acid during pregnancy after second trimester. And whenever anemia is diagnosed, that is less than 11 grams of hemoglobin during pregnancy, should be treated either with the oral iron, parenteral iron or packed cell depending upon the severity of anemia and period of gestation. When there is a risk factor, what are the precautions to be taken? Whenever there is a risk factor for PPH, plan delivery in a center where laboratory facilities, blood bank and storage facilities, skilled obstetrician and anesthetist are available. How to prevent PPH? WHO suggests all women in labor during third stage should be managed by active management. It reduces the duration of third stage of labor and hence incidence of PPH by 60%. The components of active management are uterotonics, oxytocin 10 units IM given, delayed cord clamping, then between 1 to 3 minutes, and controlled contraction by Brand Andrew technique. Previously, uterine massage was a component of active management, but studies have shown that uterine massage as a part of active management doesn't play a significant role in reducing PPH. But abdominal uterine tonus assessment by a skilled healthcare provider is strongly recommended for early identification of atony. Whenever PPH is suspected, the blood loss should be estimated accurately. It is underestimated more often. Objective estimation should be done whenever possible by weighing the pads using measurable collection drapes. Rule of clinical shock index gives approximate amount of blood loss. It is calculated by heart rate by systolic blood pressure. Normally it should be 0.7 to 0.9. Once PPH is diagnosed, the management is by teamwork and multidisciplinary care. Minor PPH, the first step is communicate, call for help, alert blood bank and laboratory, call your superiors, seniors available in the hospital. Start resuscitating the patient, access 2 IV lines, start crystalloids, IV fluids till the blood gets ready. Send blood for complete blood count, coagulation profile and blood for cross-matching. Monitor pulse and BP every 15 minutes. Every step should be taken to identify the cause of PPH during resuscitation and the cause should be treated to arrest the bleeding. Major PPH, the cornerstones of resuscitation are restoring the blood volume and restoring the oxygen carrying capacity of blood. The therapeutic goal during resuscitation PPH are hemoglobin more than 8 gram per deciliter, platelet count more than 75,000 per deciliter, prothrombin time less than 1.5 mean control, APTT less than 1.5 mean control, fibrinogen more than 1 gram per liter. Blood and blood product transfusion is a cornerstone in the management of a woman with a postpartum hemorrhage. Fully cross-matched group-specific packed cells should be given whenever possible. The decision to give packed cells is guided by clinical status of the patient rather than the laboratory reports. Group O Rh negative blood in case of an acute emergency can be given. FFP transfusion empirically can be given 4 units after 4 units of packed cells. In women with a suspected coagulopathy like abruption, amniotic fluid embolism, transfusing FFP should be done earlier. If PT-APTT is more than 1.5 times the normal, FFP is given therapeutically. The dosage is 12 to 15 ml per kilogram body weight. Platelets transfusion is given if the count is less than 75,000 per deciliter. Cryoprecipitate is given if serum fibrinogen is less than 1 gram per liter or after 8 units of packed cells. 2 pools of cryoprecipitate increase the fibrinogen level by 1 gram per liter. Identify the cause. Assess the uterine tone. Look for bleeding from perineal laceration, episiotomy. Look for bleeding from vaginal laceration, cervical tear. Rule out intraperitoneal bleeding or hematoma. Examine the placenta for missing cotyledons and coagulation profile is to be done. And always be aware that more than one cause can be present in a particular patient. That is, a patient with atonicity can also have a traumatic PPH. A patient with a traumatic PPH can also have DIC, disseminated intravascular coagulation. So before all the measures, all the resources are made available for treating the particular cause, temporary measures should be taken to arrest the bleeding, to reduce the amount of bleeding. bleeding at least. The temporary measures available are external aortic compression, bimanual uterine compression, non-pneumatic anti-shock garment. External aortic compression. Stand on the right side of the patient. Keep the left hand fist just above and left of the umbilicus and feel for aortic pulsations. Keep the right hand to palpate the femoral pulse. Give pressure with the left fist. Absent femoral pulse felt in the right hand shows effective aortic compression. Emergency effort to reduce bleeding and give time for resuscitation. Bimanual uterine compression. It is very effective in controlling bleeding as a first line measure. The right hand fist is placed in the vagina and left hand is placed over the fundus. Uterus is compressed between the vaginal and abdominal hand. Non-pneumatic anti-shock garment. It was introduced as a primary care measure to be done even by healthcare workers. It is a first aid compression garment made of a synthetic material called neoprene. It has 3 pairs of lower limb straps, 1 pelvic strap and 2 abdominal straps. It is to be applied from the ankle. The straps are applied successfully carefully. It works by reducing the amount of bleeding and recirculating the blood to vital organs. Vaginal procedures can be done with keeping the suit in situ, and when laparotomy is planned, the abdominal strap has to be removed in theatre. When to remove it? It is to be removed after ensuring 12 hours of hemodynamic stability and vaginal bleeding less than 50 ml. It is to be removed in the morning hours with the theatre and blood kept ready. Removing should also start from ankle binders and 15 minutes should be given between removing each strap. Check blood pressure and heart rate before removing the next one. If bleeding resumes, laparotomy is to be done. Now we have done temporary measures to arrest the bleeding and we have collected all the resources available to manage the cause. The medical management and surgical management. A medical management involves giving drugs. Oxytocin 20 units and 500 ml NS. It is cheap, it is universally available and the only side effect is hypotension. Methyl ergometrin 0.2 mg IM to be given. It is contraindicated in preeclampsia and heart disease. Carboprase 250 microgram in every 15 minutes is to be given. Maximum of 8 doses can be given. It is contraindicated in women with bronchial asthma. Misoprostol 800 to 1000 microgram is kept per rectally. Tranexamic acid 1 gram IV infusion is given. Intrauterine tamponade, it is used during resuscitation and transport and it also arrests bleeding. It is effective in 80% of the cases. In low resource settings, even Foley's catheter and condom catheter can be used. Other tamponades available are Bakri balloon, Blakemore catheter and Sengstaken uterine tamponade. Before applying, cervical and vaginal laceration should be ruled out and if present should be repaired. 300 to 400 ml of warm normal saline is infused after placing the tamponade inside the uterus. Tamponade test. Blood loss less than 50 ml after applying the tamponade shows that it is effective. After 24 hours, decompression should be attempted stepwise in morning hours with the theatre ready. If there is recurrence of bleeding, it should be re-infused and additional measures planned. Surgical management. Compression sutures. There are many types of compression sutures like Beelin sutures, Cho sutures, Heyman sutures. Beelin sutures is given in the image. It is basically approximation of the anterior and posterior surface of the uterus to each other so that there is bleeding from the uterine surface. Stepwise devascularization. Here we are going to devascularize the uterus by cutting off its blood supply. We all know that uterus is supplied by uterine artery, which is a branch of the anterior division of internal iliac artery. Utero-ovarian anastomosis formed by branches of uterine artery and branch of ovarian artery, which is a branch of the abdominal aorta. Here you can see that uterine artery is ligated at the origin. Its ascending branch is ligated, utero-ovarian anastomosis is ligated, and as a last result, internal iliac artery anterior division is ligated. Hysterectomy. It is a life-saving procedure and whenever hemodynamic stability of the patient is in question, it should be initiated earlier than later. Subtotal versus total hysterectomy. Total hysterectomy is removing uterus along with the cervix, whereas subtotal hysterectomy is removing only uterus, leaving the cervix in situ. Every time possible, total hysterectomy should be attempted. Subtotal hysterectomy is done only when cervix is difficult to be dissected because of dense adhesions. And subtotal hysterectomy is not a method of treatment in women with placenta previa. So other causes of PPH, traumatic PPH, perineal tears if present should be sutured immediately. Hematoma can be perineal hematoma, vulval hematoma, vaginal hematoma or broad ligament hematoma. If present, it should be evacuated. And the bleeder should be arrested. If there is uterine dehiscence or uterine rupture, it should be repaired, and if it is not feasible to repair, hysterectomy should be done earlier. And whenever traumatic PPH is there, broad spectrum antibiotic prophylaxis is to be given to prevent sepsis. When there is coagulation dysfunction, blood and blood component transfusion should be given, and whenever there is retained placenta, manual removal under anesthesia is to be done. I hope everyone who has listened through the presentation would now have a basic knowledge about postpartum hemorrhage regarding its causes, how to identify, how to resuscitate, and how to manage a woman with postpartum hemorrhage. And as an Indian medical graduate, be able to provide primary care to a woman with postpartum hemorrhage. Thank you for the patient listening.